So, Michelle, let's kick things off with what do you know about the Cures Act?
What I know about the Cures Act is that it's a federal law that was put into place back in 2016, actually, and then it was updated. And there was a new piece of the law that was implemented in April of 2021, which requires that health institutions and labs and so forth immediately post your test results to your patient portal, that they cannot block you from your own information. And this also includes radiology reports, pathology reports, blood results, and actually clinical records from visits that you have with your provider. And they do come in real time. So I'm sure people out there have seen these notifications, new test results have arrived, or new information has been posted to your portal. And so that's what I know about the Cures Act, and it has caused consternation not only for doctors who have maybe or maybe not reviewed these results prior to them being posted to your portal, but also for patients who are seeing these things in real time.
And you touch on it there, and obviously knowing your history and your background, your interest in sort of in patient advocacy. What are the biggest concerns for you in relation to the Cures Act and the overall patient experience?
Well, my biggest concern is that this law was implemented 2 years ago now, and the answer from most health institutions to the law was really sort of a posting of I'm going to call it sort of like a disclaimer, which tells the patient, basically this information may or may not have been reviewed by your doctor. So sort of a look, but only if you're prepared to see what what they're showing you. In other words, your doctor hasn't had an opportunity maybe, so you may not want to look and see. And I just kind of feel like that was great when the law initially came out, but I wonder how it's impacted patients who are potentially facing a serious diagnosis or test result and yet have, are they mentally prepared to see this on their own? And it would be great if these things wouldn't pop up before your doctors review them, but that isn't the case. The law states what the law states. So what's been done for patients in this 2-year period beyond this disclaimer? And that's really what I wanted to kind of focus on today with the group of wonderful doctors that we have who've done some amazing work to help patients.
And in light of that, what do you think is needed to deliver true patient-centered care? What sort of different approach, or maybe like are we looking at this through the wrong lens? Like what is needed?
Yeah, I think that's a great question. I do think that what has been done to date has really not addressed the concerns that a patient would have seeing this information before their doctor. Of course, when you're facing a serious disease, you're most likely going to look. I also worry about patients who may not have access to the internet, may not be as savvy in looking at their patient portal, may not even have it set up. I worry about the underserved communities, those communities who don't have internet access at all. And so what's being done for them? I am privileged in that I've done a lot of work with some amazing doctors at my own health institutions. So I have access that others don't. And I worry about those patients who don't have that type of access. So what's exactly been done? I think that there needs to be more done as far as outreach, clearly. I think that things need to be supplied to patients so that in the interim, before they hear from their doctor, what are some good resources for that patient to look at? And so primarily those two prongs. something to look at in between time, maybe setting a sort of an expectation before you order the test from a physician to say, we're ordering a biopsy. My commitment to you as a physician is to get back with you most certainly within, X amount of time. So please know that you're not forgotten, that sort of thing, sort of setting the expectation. So I guess those three things. I think you can set the expectation, provide something to look at in the meantime, and then do that outreach. And it doesn't necessarily have to be the physician who ordered the result. It could be your nurse, practitioner that you work with. There's a lot of ways to accomplish that in your office without having to burden you, as I know your time commitment is pretty intense as a physician.
Thank you. And obviously, in this discussion, we've got sort of the unique potential for conversation here, because we've got someone who's experienced the patient side, and obviously we've got the professional medical perspective as well. And so it'd be interesting to see our other two speakers react to this same question. But I was wondering, what one thing would you like to convey to the medical community about the current state of the healthcare system?
Well, with everything that is going on out there, as far as, we've all heard about AI and that sort of thing. I really think that unless we integrate, become more of a multidisciplinary sort of patient-centered sort of care team, that patients are going to continue to search for answers, and it creates even more of a void between the doctor-patient relationship, in that it becomes more almost like robots, and more impersonal. So I would encourage, the one thing I would encourage is that doctors do more outreach to their patients, and creating a more patient-centered environment. And specifically with regard to this Cures Act and these things being posted immediately, I think that there needs to be an assurance that to the patient that you're not falling through the cracks, that you are aware that these results will be out there immediately, and do what you can to humanize it.
Thank you so much, Michelle. We'll come back to some of your insights later on. But for the meanwhile, let's move over to Dr. Griggs. Jennifer, would you just please tell us a little bit about yourself and your work, and maybe how you got involved into supporting patients?
Yes, of course. Hello, everybody. I am a medical oncologist with a specialty in breast cancer, but as an oncologist, we take care of people with all sorts of malignancies. And I'm also a health services researcher and equity researcher. One of the things that lights me up the most about my work is meeting people where they are and helping them make high quality decisions. High quality decisions are based on high quality information support and patient preferences and values. That is the thing that lights me up. I went into breast oncology because we help people make decisions under conditions of uncertainty. And I find it a great honor to, again, meet people where they are and help them in that uncertainty, make decisions that are aligned with their values. So I do a lot of work in patient education. That's the most valuable thing I do, even when I'm not in the patient's room. I love to teach, and I love language. So understanding words and what they mean, and also how they're received, is a real driving force for the work that I do.
Thank you. And how does that love for patient interaction, how does that manifest, and how did that lead to you getting involved in the Yerba YouTube channel?
Well, it's quite clear to me that within the constraints that we have in our office visits, patients have information needs that we are sometimes meeting and sometimes not. Even if we explain it in the most perfect way, patients can't absorb, digest, integrate, and apply the learning in a 15 or even an hour-long session. So my work with Yerba is designed to, because the information's available, of course, one needs to have a phone with access to YouTube, but we can provide information in digestible amounts. So we try to keep our videos relatively short. People can watch them again. We have a comments and questions section, and I answer every comment or question that people ask. And for me, it's a way to try to meet people where they are and break down complicated ideas into building blocks. I have to say, no matter how health literate somebody is, no matter how many years of education they have, using metaphors and illustrations to create a picture in people's minds, I think is one of the most powerful ways to help them understand what can be very complicated, especially in really all malignancies, but breast cancer in particular. There's almost no modality we don't use, no form of treatment we don't use, and understand how those all fit together, how they apply to you, the patient, and the caregiver. I think that's what really lights the fire for the work we do at Yerba.
Thank you. And in light of that passion for the caregiver to patient, like communication relationship, in light of what Michelle said about, the lack of outreach and dealing with unreliable information, what are some of the things that you think can be used to address that issue, or what are some things that you are already doing that you've seen success with?
One of the things I think is so helpful, and I'd like to restrict my remarks to the act that we've been talking about, because I think the intention is to increase transparency and access to information so that you're not waiting to find out the result of a test based on the physician, that things don't fall through the cracks. Yet the unintended consequences are that the patient can feel that they fall through the cracks. So they have access to a report, a pathology report. It might be preliminary, it might be final, but within that is terminology and language that is obscured. So to me, helping people understand their pathology report, we do that on Yerba. We explain all the terms you might see in your pathology report. But it seems to me that there could be some low-tech ways to support people looking at their own reports, such as a glossary or links to videos that would explain commonly used terms, because we all learn differently. Some people by reading, some by listening, as well as perhaps even a hotline where people can call and there's somebody on the other end who is not their pathologist, but can explain what some of the terms mean, as well as acknowledge the uncertainty and the distress, confusion, perplexity that the patient and caregiver may have.
Fantastic, thank you. And what makes your work, that either with Yerba or independent of that, what makes your work particularly unique among other lab and patient-led patient care careers?
I think there are lots of other people doing really good work in this area, so I want to be careful to avoid claims of priority. But I do think understanding language and also the structure of conversation can help us move the field forward. So asking what people understand before we start talking, because I have been surprised over and over again with the answer to that question. So I will ask, tell me what you know about what's going on and how I can help you. And some people will say, even though they're in the cancer center, is it cancer? And another person will say, well, I have stage 3A, triple negative breast cancer, and there's a clinical trial I'm interested in. But first I need to have scans because it's stage 3 disease. If you don't ask that, how are you meeting the needs of the patient? So I do an ask, tell, ask, where I ask what they know, what they want to know. Then I tell in small bits, and then I assess comprehension, not by quizzing, not by saying, teach back to me what you've heard, but rather, who are you going to call after this appointment, and what will you tell them? Because I think we want to avoid putting people on the spot, and it's such a great way to assess what they received. A conversation isn't one person talking and another person talking. It's how we hold what we've heard. If we don't do that, it's not a conversation. It's a lecture or a diatribe or a lesson, and it's not patient-centered or caregiver-centered.
Thank you. Just jumping off of that as well. You mentioned that you really value the linguistic aspect of the communication process, and I'm interested in because you seem so passionate about it, and what part of that do you think offers the greatest difficulty? What are the big challenges in language choice and word choice and vocabulary, in your opinion?
Oh, that could be a long answer, so I'll try to be brief. I think that patients hear different things from what we mean. So I'll give an example because I think stories are helpful. When somebody has lymph nodes removed and there's involvement of one or more lymph nodes, the pathology report will say often, not always, but often, lymph node metastases. So patients look up metastases, and as you know, that means somebody has stage 4 if it's a diagnosis, or advanced disease if it's later on. And so when we really are talking about local regional involvement with lymph node involvement, in which the intent is cure, we've just told the receiver that they have metastatic disease, which is most often not considered curable. There are, of course, about 5% of people with advanced disease who will die of something else with minimal, if any, disease. But in general, the intention of treatment in metastatic disease is palliation, management and prevention of symptoms. So it's just one common example. And I have so many questions on Yerba about that with great confusion. Another example is that we often use the word, or real people will use the word aggressive. And when we talk about grade 3 cancer, we're really talking about an active cancer. I think we have to be really careful not to use words that have a meaning in English that is something a little different from what we mean. We can cure grade 3 cancer. In fact, chemotherapy works better when the tumor is higher grade. So yes, it's more active, right? The cells are dividing more quickly. They're more likely to metastasize, but that doesn't mean that the patient's prognosis is necessarily connected to that particular characteristic of a tumor.
Thank you. It's really interesting. I was just wondering as well, within the work that you've done so far, and the advocacy journey that you're on, are there any standout moments in terms of patient interactions or sort of light bulb moments for you? Just anything that sort of stood out in the process thus far?
There are a few things that I'd love to highlight. One is that I always involve patients and caregivers in the work that I do, because nothing about us without us, right? We want to include people, even when we write protocols, have patients on the investigative study, because they will lend credibility to patients who are thinking of enrolling, but also they bring a wisdom that even if I had breast cancer, which I haven't yet, but even if I had, I'm looking at it through a different lens. So for me, I have been shocked at things that I don't see, that the minute it's said by a patient or caregiver, I can see it. Whether it's a word I've used that I thought was understandable or a perspective. The other thing that I wanted to share is that giving people honest news does not take away their hope. So we often think if we talk to people about a life-limiting illness, we are, quote, taking away their hope, unquote. And that's actually not been true in my experience or in large studies that have been done. And the third thing is that patients have a body wisdom that often will surprise us. We think we're breaking news. They already knew that. They already had intuition and, again, a body wisdom that we often we fail to credit them for. It's not always the case, but I have been surprised when I've told people something and they say, that's what I thought. Or I ask people if their chemotherapy is sort of preference-based, what their gut is telling them. And you know what? I haven't had a single patient whose gut told them they didn't need chemotherapy have a recurrence. So I think we need to listen to our patients' intuition.
Thank you. What's something that you'd like aspiring or early career medical professionals to know in light of the work that you do? What's something that maybe you wish that you knew when you were aspiring towards your career? Is there a message you'd like to convey?
As much as it sounds like my patient clinician communication is long and involved, it actually saves time. It actually makes you a better, more efficient clinician to take that time. It saves confusion, frustration, disconnection, breaches of trust to spend that time. The other thing is to ask at the beginning, what's the patient's agenda? And then at the end to ask, did I meet your needs today? I wish I'd learned that skill earlier.
Thank you. And if you could say one thing to pathologists everywhere, what would it be?
I would say thank you for being part of your patient's care team. There's so many things pathologists do right. So the next statement I make is deeply embedded in appreciation for pathologists' expertise and care of their patients. Pathologists care deeply about their patients. The one thing I would say as a reminder is that at the other end of your pathology report is a very scared patient. Not always, not all patients are scared, but there's a scared patient, and your pathology report is really a conversation.
Thank you very much, Dr. Griggs. Now to move on to our next participant, we have Dr. Kene Ojukwu. For the first question, Kene, would you please just tell us a little bit about yourself and the work that you do?
Sure. Hi, it's been great listening to everybody. I am a physician, pathology trained, subspecializing in bone and soft tissue, which talks a lot about sarcoma cancers. Also, I am training in health services research to be able to take some of the work to the community and integrate the learning in the community with the pathology labs.
Thank you. And what led you to choose pathology as a career choice?
There's a long version. I'll keep it to the short version here. But essentially, I liked the engagement with all of elements that patients deal with. So I think of pathology as the background of the hospital. We run the labs, we get the biopsies, the cultures, anything that's used to make a decision about a patient comes through us first. Even within blood banking, where patients need blood, we're the ones who test that to make sure patients have what they need. So no clinical situation can really run properly without pathology services. And that broad, vast nature drew me to it, as well as the opportunity to teach. You'll find a lot of med schools, a lot of teaching happens, at least the foundation teaching happens from pathologists. So that, at least in my experience, so that drew me to it. And it's just exciting. A lot of technology is enhanced in pathology. And then there's the opportunity also to engage with patients depending on what path you choose. And there's room, and it's about thinking and being innovative in that front. So that's some of the things that drew me to pathology.
Thank you. And what in your view, what makes your work particularly unique among your fellow pathologists?
So, along the lines of what has been talked about so far, I'm trying to focus on collaborating. I'm collaborating multidisciplinary wise and also within specialty, subspecialties to create a pathology clinic for the underserved. I've engaged with the work that some primary care physicians are doing. They're, in a way, sometimes doing a lot of the educating for the patients. And I think that's a lot of education burden. And I see pathology clinics as an opportunity to share that burden with whether it's primary care physicians or oncologists, but creating a space where patients can come and actually spend time with the pathologist to review a path report or review a lab report. So we're in the process of creating that setting. It's been done in different locations throughout the nation, and has been done successfully, and patients reap benefits from it. And there's a transparency that occurs, and there's a space for pathology to participate.
Thank you. And you mentioned, working for underserved communities, and I was wondering if you could, shed some light or experience on some of the specific opportunities you've had to work for patients to learn more about, pathology in the lab.
Sure. So some of the work I did started at health fairs, actually. We'd bring 3 microscopes to health fairs, one showing normal colon, one showing abnormal colon, and one showing cancer colon. So we'd have patients come look at all 3 and then have a discussion, and we'd have the endoscopy. So like the colonoscopy pictures up that related to each of those. And just some of the stories we heard from patients and family members about seeing this and understanding, oh, okay, I need to go convince my husband to get this colonoscopy. And then also seeing the pathology trainees engage with patients and feeling fulfilled. There was an element of physician well-being, feeling renewed to see the outcome of some of the work you can do. So that's how some of the work started. And then in learning about pathology clinics and that people are out there trying to teach or at least offer guidance with reports. Patients already have access to EMR records. We need to leverage that to enhance patient care. And there's no consistent mechanism to do so. So people are filling in the gaps, but what if it was standard across, let's say, county hospitals or all hospitals where you had a place to go to review your path reports, your lab reports? I think this would be of benefit to patients.
Thank you. I know, what are you currently working on, or perhaps what are you hoping to work on in the future in terms of educating patients, continuing that interaction between pathology and patient relationship?
I think implementing this into the training of pathology trainees, that's one of my focus, because currently a lot of attendings, which are folks who are already working, are involved in the pathology clinic, and it's less so trainees, but we need to implement it into the curriculum so it becomes natural to know that you have this power to teach patients as you're training to be a pathologist, and that just opens up the field and the work and the impact that you can have as a pathologist. So currently I'm focused on that pipeline and how we're training the pipeline. And then also teaching folks that usually when technology is introduced, the most privileged of us get to benefit from it, but everybody can benefit. We just have to intentionally build a system that works. If it's not intentionally done, it's not going to just happen. And I think keeping that in mind as we engage with patients of all types is necessary. Thank
you. And just to bring it back around to the Cures Act, as as Michelle mentioned earlier, it's been a while since Cures Act came into place, and obviously there's still a lot more to be done. in relation to that act specifically, what do you think can be done to help patients understand more about their diagnosis or their disease?
Well, someone mentioned low-hanging fruit in terms of resources for patients to be able to understand what's happening. There are websites that are created out there for patients with patient input. So having those resources easily available while patients are learning about EMR, they're in the county system that I'm working now, there's certain folks who are navigating patients through technology to access EMR. So at that same time, imagine if they learn about mypathologyreport.com and they know that's a place they could go to understand the vocabulary in the reports. So I think integrating things and collaborating with what other people are doing is what's going to make this more efficient and effective.
Thank you. And obviously, being a pathologist, I'm interested in knowing what key thing would you like aspiring or early pathologists to know about what it is you do, and maybe to echo the question I said earlier to Dr. Griggs, is if you yourself, if you were to pass on a message to your younger self, what would you tell yourself about the work that you do currently?
These medical systems are complex, and the more you learn, that doesn't mean it's going to be an easier solution. So from the get-go, if you're interested in helping solve some of these system problems, start getting engaged from the beginning. The more you learn, the more vocabulary you'll have. But if you have great ideas, lean into that innovation and bring it to the right people so that you can start to change the system for the better of patient care and for education of physicians in the community as well.
Thank you, Kenny. I'd just love to basically, since we've covered all of the written out questions, I'd love to just sort of open the floor, as it were, for sort of a natural discussion between the three of you. And I'd just like to sort of reel it back again to sort of the sort of key topics we were going to cover here in relation to the Cures Act. And I was wondering if anyone wanted to say something about specifically patient safeguarding and their thoughts on that, and if there was any sort of ways, how do we move forward in light of this sort of anniversary of the Cures Act, as it were, and what sort of policy making or what can we do on an individual level to protect patients? I'm not sure if any of you want to take that, but I'll just open the floor for your expert insights.
I'd like to share, I've been working with the University of Michigan health system, and specifically the Office of Patient Experience there in the health system on this very issue. And one of the things they've already implemented is changing the information that is pushed out to a patient when new test results are posted. And it includes now a link to potential resources for patients to examine. So they've altered the narrative in the push notification. So that's number one. Number two, the other thing they're working on is through the portal that we use at Michigan Medicine. It's called MyChart. There is new functionality that is going to be added in the fall of this year, which when a test result is posted and the person goes into their portal to look, it'll have a sort of a bubble that comes up that says, just so you know, your provider has not yet looked at this information, and that bubble will disappear when the provider goes into that test result and adds a comment in. So as you can see, MyChart, the company and Epic have noticed that, more needs to be done in that regard to help patients. And so U of M will be implementing that piece. And then the third thing that they're doing, which is really exciting for me personally as a patient at U of M, is that they're going to be doing education to the provider community targeted for the fall this year. Hope to be involved in some of that. And this education is going to just show from a patient perspective what it's like to sort of get, this information and not having that outreach. And part of that piece will be setting expectations with the patients. You know, we've ordered this blood test. If there is an abnormal results, I will commit to getting back with you in a certain period of time, that sort of thing. So I'm really excited about what U of M is doing to sort of help with the situation of things being posted in near real time and doing more outreach.
That's brilliant, Michelle. It's a vanguard. That's what should be done everywhere. Brilliant.
Thank you, Michelle. Dr. Griggs, I'm interested as well in because you mentioned sort of that the fascination with language, and I'm interested in how that sort of interacts with other inequities outside of healthcare, and I'm wondering if just if you could maybe speak on sort of because obviously there's a patient to medical professional education gap, I guess, if you want to call it that, in that someone has a specialized expertise, and I'm wondering how do we sort of approach other educational inequities in terms of level of formal education, whether it's high school, college in the US, as it were, just sort of how do you approach different communities that have disproportionate effects on their education because of society?
Interesting, isn't it? Language changes, and also our terminology. I'll start with medicine, but it's no different with any other field. Our terminology makes us specialists, and with specialization comes power. So when we use words that aren't accessible to people that mean something to us, it really widens power inequities. And that's really what inequity is about. It's the disenfranchised, people who don't have power, flexibility at work, who don't have access to good education because of neighborhood it's systemic. It starts and it's embedded in our country since the inception of our country. So you've asked a big question, but I think like Kenny was saying, that structures that have separated the haves from the have-nots and have created power differentials were intentionally put in place and have been intentionally maintained. So as Kenny was saying, they're not going to come apart by accident. We have to put even more energy into dismantling the systems that keep people from reaching their full potential. Structural violence these are systems that keep people from reaching their full potential, whether it's in a neighborhood, in a workplace, when it comes to housing, when it comes to healthcare. We have to work harder than people work to create and maintain those situations. So again, it's a big question that you're asking, but I think our country is unique in many ways, and this way in particular. The history of income inequalities and the history of disenfranchisement of populations is so deeply embedded. It takes innovation and effort and resources to undo that.
Thank you. Kenny, this one might be slightly more targeted to you just because of your role as a pathologist and involvement in training, but I was wondering, is there sort of a sea change required in training in really focusing on patient best interest, because this talk is ultimately about maintaining the best interest of the patient, and I'm wondering how much of the training that you went through, how much did that focus on sort of the patient perspective, and I just wanted to hear your thoughts on that.
So I think you get trained by people, not necessarily by institutions. So I think I benefited from having quote unquote seniors that shared their philosophy with me about it patient first. But I think there are settings in which you're kind of in debt to the institution and looking out for the institution as opposed to the patient. And I think that's where things can go awry, I think, in the curriculum that's dealt. And going back to something that Jennifer said, that idea of uncertainty is something I also think we have a hard time relating to patients, and that loses a lot of trust. And that is something that can create a very unsafe space for patients. When your patients don't trust you, they don't trust the system, the institution. So I think working on how we deliver uncertainty in a humanistic way that allows people to see our vulnerabilities as a medical system can go very far, which involves understanding the communication ability that's needed, so that you can meet people where they are. I think that's big.
I wanted to just support you 100% in that, in what you just said, and to say that there are tools out there. There's companies like, there's a company called Vital Talk, and it teaches you how to sort of deliver serious news in a way that is, patient-centered. And so there are tools available. And if I understand correctly, I'm not a doctor, but I don't think that this is really something that is part of education for physicians, pathologists, laboratory professionals. It isn't inherent in the curriculum. I really think it's critical. And so I can understand if you're a physician or a pathologist who has this very serious diagnosis to deliver, you're nervous about having a conversation with the patient because you haven't been trained in it. And just like a physician needs to be trained in how to use do surgery or, some very technical thing, it requires training that is practiced on a regular basis. And so I totally support what you're saying, Kenny. And I think it has not yet been a part of sort of the training of a physician, resident pathologist. And I think it really needs to become a part of it. We're moving towards patient-centered care, precision medicine. Patients will expect to be treated as a whole human being and are going to seek out institutions that offer this kind of service, if you will. I mean, we're getting it on our Apple Watches now. Not only is it going to tell you how many steps you're taking, but it's going to begin to know, as a patient with your permission, whether you have perhaps a heart condition, and then sort of, you would have to grant that permission to the Apple Watch, but it may then say to you, hey, listen, you need to get moving today, or that sort of thing. So, I think patients will seek out institutions that offer this.
I have a question about the CARES Act, and that is, what evaluation has been planned? Usually when we implement something new, we want to have an evaluation. And I'm curious if Michelle, or if any of you know, if there is an evaluation plan. We have our stories, we have our gut feelings. Do we have data that this is a good thing, a bad thing, or somewhere in the middle? I'll be surprised if there isn't an evaluation. Of course, laws are different from programs. So a program deliberately, created by Medicare will have an evaluation piece to it. This is a law. And I'm so curious if an evaluation was planned.
I think that's a great question. I did read the 2022 report to Congress regarding the CARES Act and its update. And it mainly focused on additional phases. And there was one implemented last year where they are allowing vendors like Epic to grant access to a patient's medical data with their permission. So that's what the report focused on. However, I am familiar with a couple of studies that have been done. One was by the AMA. It was 1,000 patients across the country were asked, do you want your test results to continue to be posted? And surprisingly, I believe it was over 95% of the people said yes, they still want that to be posted immediately, even if the test results are abnormal. However, with the abnormal test results, they also asked a further question of these patients. When would you expect to be contacted by your physician, especially if the test was abnormal? And most patients responded to 6 hours. Their expectation is within 6 hours, they will be contacted. So within a day, basically, of the posting. So, and I think there is a compassion problem, I would say, in the healthcare industry. And as we move to more technology with AI and all these other things that are available, technology-wise, the gap is widening. So we need to close the gap. Patients are saying they want the information, they want it as soon as possible, but they do want that human touch. They want their doctor to contact them.
I would just like to add, since you brought up compassion, that clinicians and other healthcare workers are suffering greatly right now. That there's a great deal of suffering among physicians with rising suicide rates, same with nurses, physical therapists, everybody in the healthcare system is suffering. And I think, as a compassion advocate and dignity advocate, I can't not say that. So, and of course that will affect the patients and their families.
Yeah. And I think the system is hard for the different parties involved. I think part of it is kind of realigning our mission. We need healthy physicians, healthy nurses, healthy medical professionals to be able to help patients be healthy as well. So we should see some of the output as an indicator of what needs to be fixed within the system. Which is, if it's a compassion problem, part of it is because there seems to be no compassion on the system. And so it's a complex thing.
It is. It really is. And everybody has their own perspective. And you're absolutely right. These last few years for all of us have been particularly hard. And there have been burnout issues within the medical industry that we don't even know the impacts really. And some have been impacted by, this pandemic personally. They've had COVID. Maybe they have long haul. So there is a lot going on right now. So it is sort of a lot to ask of our doctors and nurses and professionals. So it is a complex issue. You're right. But one small step. You both are doing wonderful work. I'm privileged to have come to meet you and know you. And I'm honored by the work you're doing. One small step. We can all take a small step, and you are taking gigantic strides. And I am so honored to have met you all and applaud your efforts. So it's been an honor.